And now we move on to Dr. Praful Maharana, who will be talking on PK,
DSEC.
DSEC.
So, good morning, delegates. And so, I'll be speaking on this topic, DSEC and its significance in the era of DMEC. So, why this talk? Because wherever you go nowadays, you see a lot of talk about DMEC, and decades back, I think PKP was replaced by DSEC, and now for corneal endothelial disorder, is the DMEC is the procedure of choice. But there are few situations where you may have to go for a DSEC. So if you look at this table, so this is where I have highlighted which are the advantages of DSEC over DMEC. Visual outcome wise, both are almost at par, but DMEC is better because a large proportion of patients they get 20/20 vision. Learning curve is definitely easier with DSEC. Amount of manipulation of tissue, so this point is not for those surgeons who have done more than 1000 DMECs, but for surgeons like me who have done hardly 50-60 DMEC. Now the manipulation of tissue that is being done for graft attachment significantly more in DMEC compared to DSEC, and that may translate into your early endothelial loss in cases of DMEC. Post-operative graft detachment, even with experience, and this can be a problem, and it is definitely more than the DSEC. Endothelial loss, again, if you are expert enough, then DMEC, the endothelial count may be as good as DSEC, but for less experienced surgeon, definitely DSEC is better. Final visual acuity is definitely better with DMEC. And donor age, this is an important part for Indian surgeons. Why? Because we get a lot of tissue of optical grade of 15-year 20-year age, and those tissues are really tough to use for DMEC, but you can use those good quality tissue for DSEC patients. So these are the advantages of DSEC that you can get over DMEC. Now I'll go through a few case scenarios where I had to do a DSEC instead of DMEC, and there I'll highlight the special situation where DMEC is useful. This was a case of ACIOL with corneal decompensation. As you can see, the haptic are visible here. It was a huge IOL and it was impinging on the angle. So first I did the epithelial debridement, and as a routine I prefer corneoscleral tunnel incision for my DSEC cases. So this was the corneoscleral tunnel that I prepare, um, and this was a haptic, so it was a big aisle. I had to cut it and remove it. So before removing the aisle, the routine steps of DSEC like decimet scoring is done. Now since I am not bothered about the endothelium, so I can go in and cut the aisle into two halves and then try to remove it. So this is the first half. As I am trying to remove the aisle, you can see a lot of vitreous blob is coming out. So whenever this vitreous in chamber, doing a DMEC is difficult. Why? Because the vitreous stand may not allow your graft to unroll comfortably. So that is a problem. So we put an adequate size Kelman multiplex ACIL, and we went out with a DSEC. Again with ACIL in situ, doing DMEC will be a great challenge. So for such cases, it's better to use DSEC. This is the standard technique that I prefer, biomineral technique of graft insertion using Bucin glide. And as you can see at the end, it was a nicely placed and graft was well attached. So such cases it's better to go for DMEC compared to DSEC. This is a graft representation I am showing you because in western countries you get a pre-peeled DM roll, but in India most of the time is the surgeon who has to prepare the roll, and if you don't have that expertise, you may lose some of your tissues. But in DSEC it's not a problem. If you have an automated microkeratome, it's all automated procedure. You just need to press the foot switch and everything is done. And second, you can customize your graft. As you can see here, you can measure the thickness. If you don't have access to microscope integrated OCT, you can use even pachymetry also. So this was another case. It was a one-eyed lady, 80 plus, and she was aphakia with corneal decompensation. I didn't want to go for SFIL because there was associated glaucoma. So my plan was just to clear the cornea using a DSEC graft and give her some reasonable vision. So as you can see, I was doing decimet scoring. The cornea is a little bit opaque. The visibility is not that good. So again, poor visibility is an indication where you should go ahead with DSEC instead of DMEC, because while manipulating the graft inside, you may struggle a lot. Since it was aphakia, there is definitely a risk of graft falling behind. So what I do normally in such cases, I put a stay suture. There is a 10-0 monofilament suture. So in case my graft falls back, I can pull it up with that. Then the rest of the technique is same, using a Busin glide graft incision was done. And once I am sure that okay, my graft is well attached, then I'll cut the sutures and remove those stay sutures. So in such cases, aphakia with extensive pass with glaucoma, where you don't want to take a chance, and a 80+ year lady where you don't want to do another procedure, in those cases it's always good to go for a DSEC rather than DMEC. This is another video. It was a case of ocular surface disease with failed graft, as you can see here. And in such cases, again, it's good to go for DSEC compared to DMEC, because I'll show you in later half of the video. You will notice there is a iris adhesion throughout the graft host junction. So in such cases, where the visibility is not good, the entire segment details are not clear, or the entire segment has a lot of issues like extensive iris synechia, in such cases, it's better to go ahead with a DSEC compared to a DMEC. As you can see here, graft attachment is little, centration is little bit difficult because of the graft host junction. But with experience, you learn how to bring this graft to the center. And this was the microscope integrated OCT picture. As you can see here, graft and the graft host, this is the graft host junction, and there is a clear good distance from the angles. However, if you notice here, see here, there are adhesions here, right? This is the graft host junction, and the iris was stuck there, and releasing those synecdoche and then performing a DMEC, again the DM will not unroll and centration will be an issue. So for such cases with extensive pass and synecdoche, it's better to go ahead with a DSEC rather than DMEC. This is the last video. This was a case of CHED. In all these cases, the visibility is so poor you cannot even try DMEC. In such cases, definitely DSEC should be the procedure of choice, and DSEC is quite useful and it gives excellent result. These hazy cornea, they usually clear over a period of 2 to 3 months, and at times you will be surprised how clear the cornea becomes after DSEC. So with this, I conclude here. So to summarize, whenever you find that the entry chamber is has some difficult scenarios like vitreous, synechia, the visibility is poor because of corneal haze, the patient is aphakic and you don't want to do multiple procedure in that patient, complicated cases, or the patient is having implants, glaucoma implants, or the patient have large iris defects, hypotony, or there is coexisting procedure that you need to do, or in patient whom the medical or social reason that doesn't, that gives you only one chance, you have only one chance to take the patient to OR and do the procedure. So in all these cases, it's better to go ahead with DSEC. And with this, I'll conclude here. Thank you very much for your kind attention.
Situations, I agree with you that DMake, although may not have that interface related issue, may not cause hyperopia, etc. But there are complicated scenarios wherein you can have a comparable outcome with an ultra thin DSEC, and that's what you emphasized on, and we completely agree.